go up through the arteries, capillaries, delivery, nutrition and oxygen, and it picks up the carbon dioxide and waste, and then gets rid of it. That's perfusion, all through the body, everywhere, every cell. So the goals for this is we're going to be able to define and describe the concept, which we pretty much just did on this previous slide. Notice risk factors for impaired perfusion. So when you were in Adult Health 1, you learned about PVD, right? So what was one of the symptoms, the signs of that was going on? Please don't forget, this is stuff going to be on NCLEX, you know, I mean, you need to know this stuff. Qualification, right? Pain with it. So noticing that's one of the factors, and we will go over those for what the exemplars we're doing. Recognize when an individual has compromised. What's a quick assessment piece that you know? Calorie fill will be delayed, right? That would be one of the signs and symptoms of that. You can recognize that and provide appropriate nursing and collaborative interventions. Those of you who were on the cardiac floors are going to be really well off for this test, right? Because you're going to be seeing this stuff all the time. And then you go to the next one, it's going to be respiratory. So while you're in your clinicals, you probably want to be aware of what relates to the concepts that we're studying. You will learn a lot in those. I know it's overwhelming when you're in there, but you will learn a lot that you'll be able to apply. And we have heard from students that, oh, I learned that when I was on or whatever unit it was. So pay attention when you're there. Ask the nurses, talk to them, talk to the patients. They'll tell you a lot about signs and symptoms. These are the interrelated concepts. So perfusion, gas exchange, right? O2 and CO2. So you gotta have good perfusion to do that. Relates to that. Pain, complication, DVD. How about clotting factors? Perfusion, right? That's a perfusion problem. Alrighty, condition. If you're not getting brain flow up here, what's happening? It's not working. It's not working. When you start having showing signs and symptoms, that sometimes it may be a carotid artery that's blocked, and you got people that are there. Oh, my mother is like, she's forgetting everything and she's lost. Well, maybe if we open up her blood flow, she might be okay. It may not be Alzheimer's or dementia. Ah, yeah, okay. Mobility. Can you get around claudication we were just talking about with PVD if you don't have good perfusion? Will it affect that? Elimination. Do you have mobility in your gut if you don't have good perfusion? No. It'll stop working. It'll slow down. Okay. Inflammation. Well, that is a good portion of helping actually protect a wound or an illness, and then the perfusion will also help clear away that inflammation after you heal, like with a wound, right? It's hot and you get cut. All the perfusion is bringing all that stuff in there to help heal. Patient education. Oh, do we teach patients? From the moment you meet them to the moment they go home, you will be teaching them something, some way or another. Whether it's just about the foods they eat, or maybe you want just informing them and teaching them about the doctors and the care they're going to be in. You're going to be teaching them. And then nutrition. Is that important? The only way you're going to stay healthy and maintain your health is if you're eating well. Right? If you're eating the right things. And that's part of the teaching we'll be doing. Okay, so in your perfusion, this covers all of these exemplars, but we're not studying all of these. We will study quite a bit of them. Dysrhythmias, valvular, shock, heart failure, cardiomyopathy, endocarditis, pulmonary hypertension. More of that will be in your respiratory than it is going to be in here, but we touch base because they're linked together. It's cardiopulmonary because you can't have one without the other, right? Okay. Myocardial infarction, embolism, sort of, not a whole lot. Arteriosclerosis will cover. Hyperlipidemia has been in every course you've talked about, though, right? Somewhere down the line. Even kids have it. With fatty livers and things, right? Hypertension, you already did sickle cell stroke, not so much. DIC, I'll touch base on it. You're not going to get a lot of questions on that in the testing and in NCLEX and testing and that. You will get some. You have to understand the basic what's happening. Okay, so mainly what we're going to be covering is going to be our perfusion and how perfusion will have poor heart failure, myocardial infarction, but if you have one of these, is that going to affect your heart? If you have one of these, this should be down into here too. Will it cause dysrhythmias? And shock, if it's really bad, your perfusion is really bad, causing one of these, it can cause that. And we will cover that in the CHF shock lecture, which is for you guys next week. Key terms, ischemia. You do not receive enough blood going to the organs. It will cause ischemia. We will cover some of that when we're talking about the MI coming up here in a little bit. Infarction is when there is no blood flow or it is so compromised that it shuts off, and if the blood is not reaching the cells, do they live? So infarction is the cells start dying. And then we have anoxia, that's just the absence of it. Is it permanent? No, it can be just a simple blood clot moved through, you went in and pulled it out and it restored it. So, you did this. Yes, you did this. There was a reason I had you do that to come into class, because knowing how the blood flows to the heart muscle itself and feeds it is different than the blood that is going through the heart, right? So you may be getting good heart blood in and out of the heart, but then you get numb here. Is that going to then affect this? So that's why you need to know both of them. You need to know how it feeds the heart and then how it works in and out of the heart. So our central perfusion, this is the blood flow that goes after we get it through here. Where does it go? Well, it goes down into your capillaries, exchanges. This is important for your respiratory too when it comes up on the next one. Picks up the CO2 and then returns. So this is how we get our blood oxygenated and given the CO2. So it's important to know that not only for perfusion, but for respiratory, it's cardiopulmonary. It's going to tie into this all through this whole lecture. So what is our central perfusion? That is the force of the blood as it's moving, generated by the cardiac output. So the amount of blood coming out of the heart to the body. Cardiac output. So our cardiac output is measured, the stroke volume, which you do not need to know how to figure it out, unless you go to ICU. Then you'll learn how to do it. So don't worry about doing that in here. Just know that it's stroke volume times heart rate, and that's how they determine what the cardiac output is. That's all I need you to know about that. You'll learn more about it when you take, critical care. Program. All right, requires adequate, we have to be able to have good function. You have to have a good pump. That heart has to actually push that blood against resistance, right? It's not just an even flow. They have to push it up and out and over, and it's got to go through the rest of the body. So if you don't have good pumps pushing it and keeping it pushed, it's not going to do well perfusing anything, is it? In the local perfusion, these are your capillaries. This is the small arteries and veins that are there. And they have to have the ability to be permeable to exchange that CO2 and O2 from the cells, to pick it up, to deliver and pick it up and bring it back to the heart so that we can exchange it in the lungs. That is your local. Central dealing with it coming out of the heart. The local's going to be the rest of the body. Okay? Good. So here are some terms that we need to know. Cardiac output, we talked about that. It's in the central perfusion. It's the amount of blood pumped by the ventricle in liters per minute. again, you need to know that you have to have adequate cardiac output to maintain adequate perfusion. I'm not expecting you to know how to determine the liters and how it works and what that, just know that it has to work, it has to be good output to reach everywhere. I mean, you're not talking just reach here, I mean, it's got to push it all the way through the body. Systole, the phase of the cardiac cycle when the ventricles contract and push blood out into the pulmonary arteries and aorta. You will go over that a little bit more when you do the dysrhythmias next. That's next after this lecture. Oh boy. You didn't know that. Diastole is the phase of the cardiac cycle when the ventricles get a chance to fill back up again. So if you have a fast heart rate and it's going, can that heart fill? No. Can it pump out good? Are you going to have adequate perfusion? Are you going to expect a lot of problems from this patient? Yes, definitely. Okay, stroke volume we talked about. It's the amount of blood that is ejected with each heartbeat. Preload is the amount of stretch of the cardiac muscle, the fibers, at the end of diastole. So when they're saying they're having preload problems, it's not stretching. It's the easiest way to put it. Contractility is the ability of the muscle to shorten. Remember when they had anatomy and it said, oh, when they contract, they go out, and then it comes back together, and well, that's it. That's the ability of the heart muscle to act like that, is to come back. Is that going to push the blood out? It fills, so it stretches. If it can't come back, you can't push it out, can it? Afterload is the resistance. So when the heart is trying to pump it out of and into the aorta, that is where the afterload comes in. So if you have some issues going on down the railroad track here, that's going to affect your afterload. Let's say you have peripheral artery disease, PED. Is it going to have a hard time pushing against that? Is that going to create a high pressure system for the heart to pump against? Is that good long term for the heart? No, we'll cover that in CHF and how that affects the heart. So that's the afterload. It's going after the heart has exchanged all the CO2, got picked up the O2. When it has to pump out afterwards, if there's issues downstream, they're going to have a problem. Kind of easy way to remember. Good? Okay. Ejection fraction. Okay, your ejection fraction is the amount of the blood that is ejected with each heartbeat. So, you would expect that 100% would be great, right? Not the amount of some of the blood still remains in the ventricle before after contraction. So you have a regular value that's 50 to 65 that is normal. That is what a normal heart should be able to pump out at least 50 to 65% of that blood contraction. However, if it's higher than that, what could be forcing that blood? Go back to your diagram that you colored in. If it's forcing that blood to come out, where is that blood coming into the heart? From pulmonary, right? So if the pulmonary has high pressure, is that going to affect the amount? Is it going to push that blood out? Is it going to make it come out of the heart because it's pushing downriver, upriver? It's going to be pushing it out. Is that going to create a higher pressure? So it's going to be higher, it's going to push it out. So you will have, instead of 65 or 70% of the heart getting out, it may be above 70. And it's pushing all that, more of that blood out because what's coming behind it has got a lot of pressure. Does that make sense? Okay, good. Any questions on this so far? Does it help you understand? You get some blank stares. I need bobbleheads. Yeah, good. So what happens if the heart, your central perfusion, right? What happens when you have inadequate amounts? Well, you have reduced cardiac output. Remember I said you didn't have to know the numbers. You just have to know that it's reduced. So if it's reduced, it's going to cause other issues to reach the body tissues. If it's severe, it may be associated with shock. If you can't get enough blood to the rest of the organs, what happens if you don't get enough blood with the kidney? Which you will get back starting next week. You don't get good output from the kidneys. If it's not getting blood, is it going to work? No, it's sort of like that short in the light switch. You know, sometimes it's going to do okay and sometimes it's not. You're not getting good, steady flow. If untreated, it can lead to ischemia. Ischemia is inadequate blood supply. What can happen then if you don't fix it? The cells they're injured, they start to die off, and then you have cell death. So what are some of the manifestations we have when we have myocardia, ischemic, and infarction? MI. Okay, we're going to talk about the MIs and what it means. They report, we said, pain, right? If you're not getting good blood flow, the cells will respond by hurting, sending you the pain signal. This is not working. Hey, 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 I need help down here. You need to help me. So it's going to have chest pain. Again, cardiopulmonary. If you're not getting good blood flow to the lungs, are the lungs going to work? So how that reacts is you don't get enough oxygen and CO2 exchange, you get short of breath, you get dyspnea. You have peripheral edema and weight gain. So if the heart is not getting enough blood, because it's under attack as an infarction, can it contract well? If it can't contract well, what happens to the blood? It pools. If it pools, you're going to have edema, because there's water in the blood, right? It's going to sit there. It's not going to exchange. The cells aren't going to exchange any of that. So it accumulates. And then you have weight gain. Because that fluid, it's not getting to the kidneys to be perfused, to be made into urine and go back to the body. So perfusion affects that. You'll have fluid. Fatigue. If I'm tired, I've been walking all day, I'm good. You have a reason to be tired, you've been using up your glucose, all that other stuff. But if you're fatigued, when you have an MI, it's not blood flow in there. It's not providing the oxygenation that is needed for the cells. So they're going to be tired. They're going to be fatigued because they're not getting enough oxygen. Dizziness, syncope, changes in level of consciousness. What did I say about the blood flow getting up here? It's going to affect the brain, right? And to the point where they may go unconscious because they're not getting enough blood. That's when they're going to go into shock, which will next week. Don't want to put all this on at one time. Nausea and vomiting. We get blood flow to the gut. Makes the heart, the whole GI tract move. What if we're not getting enough blood pump there? It's stagnant, right? It's not moving well. You get nauseous, you start vomiting. Women often remember this. This is so important. Women present with different presentation of an MI. I will tell you personally, I'm a cardiac nurse here, guys. I've taught cardiac nurse for 24 years. Had a patient that came into the ED, had an upper jaw pain, went to the dentist took x-rays, it's nothing up there, but still had an upper jaw pain. And that was the only symptom. Thank the Lord, we had a wonderful tech there who said, I'm going to put them on an EKG. Did an EKG and found out that they were having a heart attack. Now this is day 2 that this woman was having issues. The only presentation was upper jaw pain. Yeah. There you go. Women present different than some men do too, but mostly the women present different. Okay. So, how do you assess? You know this. right? PQRST, the questions you ask your patient when you're asking about pain, it's not any different than for cardiac pain than it is for any other type of pain. It's the same ones. Do you want me to go over these? Okay, I didn't know so. You've been hearing this since intro. I know, I just came out of intro course, so we start teaching it there. All right. So here are some examples of the different types of presentations of chest pain that don't always mean chest pain. May not be an MI. So if it's up here in the middle, and anybody with an anxiety attack, anybody have anxiety attacks? Do you feel like your chest is caving in on you?
Yes.
Okay. What's happening is you're anxious, your arteries and veins clamp down though because you're anxious. Does that give you good blood flow? Is it causing a heart attack though? No, but it's still going to give you pain because the cells are saying, I'm not getting enough down here, which only makes you more anxious, which is a bad cycle, but that's what's happening. But it'll present right here in the middle. You have over here, this is esophageal. So if you're having reflux, where is that going? Right behind the heart, right? But you don't know that. You don't know. You just know right here is where you're having pain. But do you see how that would mimic having an MI? Okay. Over here, musculoskeletal. This can happen when there is an injury to the rib cage. It can be anything, and it sore, so you don't know. And it presents just like an MI, or at least the classic presentation. Pericarditis. We've heard about a lot of this in the last couple of years, haven't we? Having pericarditis. Well, if the pericardial sac is inflamed, is the heart getting the expansion and contraction? So cells are not getting all what they need. So they're going to say, hey, I'm not getting enough, and it causes pain. But that's where it's going to present, where the pericardial sac is. We have PE, pulmonary embolism or pneumonia. So it's going to affect more of where the end of the lobes are. So sometimes people think they're having a heart attack, but they're not. But here are your classic symptoms, where it's having here, and it goes over, and then it radiates. You know the R, QRST, right? It radiates down the arm. Coming out, the blood is coming out in the heart, the aortic arch, right? So that's right here is the blood flow, and they're going to start feeling it here right away. You have on the back side, of course. You can have right side if you have, the heart sits over here. It's not smack on this side, over a little. So if it's having an ischemia on the top part of the heart, it may present on the right side. And the back, because you're feeling it from here. It's not into the jaw because it comes out the aortic arch. We have what's feeding the brain. Right? Often under the clavicle. Blood comes up over here and then down into the arm. This is when you get this and you get it up into the jaw. So those are where you're going to find them. So we have another way that is going to cause pain in the heart. And it's a coronary spasm, where there's not a total blockage. They still have blood flow through it. Not like here, where the blood clot just forms and forms and forms until it stops the blood altogether. This is just where you have a muscle spasm, right? You know what that feels like. Is it constant? For a little bit, and then it eases up. Well, that's what a coronary spasm over here will do. There are 3 different types, and we'll go into those. But they can, if they're not treated, cause inadequate perfusion to the heart, right? That can also cause a heart attack. So, 3 types. I love this name, Prinzmetal. Prinzmetal angina. This is the spasms. Okay? It is causing a spasm that it releases. Comes at any time. It's never, you don't know when it's going to cause, you don't know what sets it off. It just causes spasm. You don't know when you have muscle pain or whatever. It just happens, right? But there are drugs that they can do that can give them as a calcium antagonist that will help this from happening. But the big thing is they want you to get treatment right away because sometimes, well, maybe it's not, but you gotta have it checked out. But if you're known to have it, they'll give you medications that will keep it under control. So nitrates, nitroglycerin, it's good to have. That will help open up the arteries. It helps them relax so the blood can flow through again. Now, when we're getting into the other types of chest pain on these, we have angina pectoris. This is the one that there may be a tiny plot. They may have a plaque growing in the artery, and maybe, let's say, they went and hiked up the mountain, or they swam across the channel here, and went to the other side of the beach, or one of the islands that are off the coast, right? They got over here, and they started having chest pain. Well, it wasn't enough to stop the blood flow, but it was enough to hinder it. So the body wasn't getting the oxygen that it needed. Then they go get checked out, and they say, oh, you got 25% block in such and such artery. They know it's there. They're not going to do anything about it right away. I mean, why risk maybe infection or causing a blockage further down the heart or whatever? They're going to watch it, and they're going to give you medications to help control this. Keep the arteries open, maximum that it can do. Put you on lipids so you can kind of keep that from growing underneath and lining. These are the people who, they know, I'm going out, I'm mowing the lawn. And I know I can probably get about halfway through my lawn before I start feeling the chest pain. I go in, I relax, it goes away. I can go out, I can finish what I'm doing. They know their limits. They know it's gonna happen. The weekend warriors go do what they're gonna do, but they know they have to rest in between to give that time to relax enough to restore the blood. They also have medications for it, like nitro. They may have been out there cutting down limbs, and they start, they go in, they take their nitro, and they know that it goes away, and they're fine. They do their thing. They go on. Now, I have the guy that's sitting at home, 7, 8 o'clock at night. He's sitting in his easy chair, he's watching TV. He's never had this before, or maybe he knew he had some and it was mild, but he wasn't doing anything. Or he wakes up in the middle of the night, crushing chest pain. This is the unstable angina. This is the one that is most likely in the middle of a blood clot is stopping at that, where that fat, lipids, whatever you want to call it, was in the lining. But now the blood has stuck together so much it needs to clot. That's unstable. That's an emergency. He was at rest. He wasn't putting any exertion on his heart. He wasn't increasing the demands for oxygen in his heart. It just happened. Most likely a blood clot. Or a fat or something that actually blocked the artery, not the lining. Is it slowing the flow down? It's stopping the flow. Does that make sense? Yes. All right.
This is a tough crowd.
Okay. Complications. Well, I think you've seen enough of them, like Grey's Anatomy and all of them. Complications. You're going to have, you can have an ST elevation. This will make more sense to you when you get your dysrhythmias. Okay, it's a certain portion of the EKG that says I'm having a myocardial infarction. A non-standing where you may have symptoms of having a heart attack, but it hasn't changed your EKG to raise the ST. And then, like I said, this is going to become more clear later on. So you have STEMI, ST portion, elevated MI. Or you have a non-STEMI, which is the ST is not elevated, but you can still be having an MI. STEMI, we know you're having an MI. Non-STEMI, you may not. Maybe you're having pressure on your chest from anxiety. It may, because it's going on for a long time, cause some ischemia. Like I said, it can, if it's swollen in there with costochondritis. It can slow the blood flow enough down to make the cells scream, but it's not an allergic MI. Does that make sense? Okay. Most of the complications will present less than 24 hours after the initial onset of this chest pain, myocardial infarction, or ischemia. But the mechanical complications can occur anytime after that first week. They may have damages that you may not know about after the first day or so, and then the cells still have not got perfusion back. They were injured too long. But it may not present until a couple of days to a week after. So you can also have reinfarction. If they had it, let's say they had it, we may have thought we got all the clot. Let's just say they went to a cath lab. We'll get into that later. But it didn't, or another one followed behind it. And they can call a reinfarction in that, or the area we did not get the blood flow restored well enough that it was functioning better again, and it can still cause more damage to the rest of the heart. So long-term complications can include hypotension and CHF. When we do the CHF, we'll talk about how the heart muscle is affected from an MI and how it can cause hypotension. Okay, and that will be CHF. Electrical complications, you're going to go into that today when you're learning about your dysrhythmias. If you have a portion of the heart, electricity, she'll go into this, but it runs from here, it runs down this way. But I've had an MI right about here. Do you think that electrical activity is going to go through there very well? No, so it can cause problems there. Cardio, we've talked about the cardiopulmonary, but the cardiac sac also can be affected, even though it's not the actual heart muscle, but it is the lining around it. There can be complications if the heart muscle isn't working well. And then aneurysms, you can have blood clots, you can have bleeding complications, anything that you have studied before with your perfusion, thrombophlebitis, any of those that you have, PED, any of that can be caused if all of this has occurred. Okay? It's all interconnected. So I said you're going to be pulling back of stuff you've learned from there. Don't forget it. Because it is affected. The heart affects everything. You don't have blood flow, it goes. Bye-bye. Just the way we're designed. Okay. So how do we diagnose an MI? Well, we're going to get an EKG, and we can see the heart rhythm. Is it normal? Are there some aberrations in it? Is it an MI, ST, elevated MI? Is it not? Is it something else causing it? So you get that first. We're going to get cardiac enzymes. This is the blood test that they will do. Several of them. You got CKMB. Now, your creatinine kinase, it is not the only indicative of an MI. Let's say you ran a marathon. You did a 13.2 or whatever it is, a 26.1, whatever they are. Do you put wear and tear on your muscles? So it will raise your CKMB. So anytime muscle is involved, it will raise the CKMB. We have patients that have fallen and not been able to get up. You know, the commercial, they have no one can get up. They lay there for a while, it's putting pressure on that. They will also have a CKMB that is elevated, not specifically the heart. However, if the heart is damaged, it will rise because the heart is a muscle. It peaks 4 to 8 hours, 12 hours. It starts, you can start checking it in the blood. It'll start showing up about 4 to 8 hours. Max, it will start returning back to normal in 48 to 72, provided there's no other injury to the kidneys that can show getting rid of our waste and things, right? Okay. Your troponins, though, this is cardiac specific. It will definitely, if you have increased troponins, it is a heart attack because it is cardiac specific. Now, You may have a slightly raised one if you're having issues with your kidney, but will the heart affect that? So it may give you a little bit. It also starts leveling up at 4 to 6 hours. It will peak, if it starts coming out here, it will peak in 14 to 18 hours. However, it may not show up if it's the non-steady. It may not start showing up until up to 24, 36 hours. But it won't be raised really high like it is with a steady. It would be slightly elevated. But it can take that long for it to start showing up in the blood. And it will eventually turn back to baseline 6 to 7 days. Takes a long time. Takes a long time for the muscle to recover from everything. Chest x-ray. Now, the chest x-ray isn't going to show that there's been an MI, but if they've had, they call them silent MIs, patients don't even know they've had them, it may affect the heart and it become larger and enlarged. We show a big silhouette. It also shows aneurysms. Coronary angiographic, this is where they're going to shoot the dye into and watch it on the monitor to see the blood flow, and they can see where it's not being and it continues. Echocardiogram, non-invasive. They like to do this usually while they're waiting for blood tests, but they'll do that because it's just an ultrasound on the heart. They just look at to see, and what they're looking is to see if the valves are closing good and bad, if it's large, and they can see the cardiac output, the ejection fraction. They can see how much blood is being pumped out from the ventricle during this echocardiogram. Now, your troponins and your CKMB may or may not be run over 3 days. It's a one-time draw, but your troponins are going to be drawn at either 3 or 4 hours. It depends on the hospital. Some run them every 4 hours until they start declining. Some of the hospitals run it every 3 hours until it starts declining. They're done every month. Quite often. And then there's a calcium scoring test, which they will use the CT detect calcium deposits. They put a dye in you and they watch it. It's non-invasive. People who can't tolerate having a heart cath, they will do a heart catheterization. They can do a CT to see if it's a calcium instead of lipid plaques causing the issue. Good? Okay, so how are we going to treat them? Well, number one is we want to preserve as much function of the heart as we can, because it's only going to affect the body more if you don't restore it to the best it can do. We have many medications that we can use on these. So we'll go into these. Your beta blockers, they're going to help smooth out that lining. It's going to control the heart rate. We don't want the heart rate doing this all the time, right? That's really overworking the heart. We want it to control, but let it fill up. You'll get a better output than you do if it's going so fast. So they slow down the heart rate and then smooth out the lining of the arteries. Inoterps. So, inoterps will make the heart slow down and make it contract tighter. So you're getting more push. It slows the heart rate down, but it pushes and contracts tighter. That's your digoxin is one of the, there's others, but digoxin is one they use a lot. Calcium blockers, we're going to prevent, it works with the exchange of electrolytes in the heart muscle to help it function better. We have ACE inhibitors. ACE inhibitors are used to control the heart rate for it. It will lower BP. If you've got high pressures, right, that's going to affect the afterload. Correct? My blood pressure is high. That means there's a high pressure in the aorta. So I want to keep that low so the heart can push out against it without working too hard. Make sense? Yeah, good. Okay, and they can affect the preload also. All right, thrombolytics, they can give them, do you know what the thrombolytics are? Okay, clot busters. Yes. So they are using it for the heart, especially arterioles that are feeding the heart muscle. We want to save them too, and if they can't get down there with the heart cath to roto-rooter to pull it out, the blood clot, they can inject out to place there to let it help it dissolve. Those small areas, because if they go in there with that heart cath, it can rupture. We don't want to do that. So they can get some of the smaller blockages they can't open up with the outspice. They use a stress test. Stress test can be either medicinally induced or they can do the treadmill. Depends if the patient can do it. Some of them have lung issues. Can they do a walk on a treadmill and get their targeted heart rate up to 160 for 5 minutes to see the blood level? They would give them a chemical because they're laying in bed and they give it to them. It makes the heart work, but it doesn't have to do that pressure on the lungs. And PCI, this is percutaneous intervention. This is used definitely for the unstable anginas. However, it may be used for your non-stenties who they can find no other reason they may do a heart cath just to see what they can see of the arteries and see if there is one that's blocked, but it's not causing it bad enough to make it be unstable. Does that make sense? Okay, go ahead and take 10 and we'll go on from there. Rest and anxiety management is how we're going to treat it, along with what we just talked about. Continuous cardiac monitoring. You have to have them on there to see, because the further along they get into blood flow being compromised, they may develop changes in their EKG. This is why you're going to have them on continuous monitoring to keep an eye out for that. Assess for complications and consider your percutaneous coronary intervention, PCI. That's what we're going to talk about. So, your STEMI. It's an emergency. It needs to be taken care of immediately. It is time is muscle, and that blood, that clot is absolutely preventing blood flow from getting into the muscle. ECG, again, large bore access IV, you may need to give multiple meds. You gotta have good IV flow. Troponins, you're gonna draw your labs, we're gonna do Mona B again. We're also going to give them heparin. This is going to prevent the blood from further sticking on the clot that's there. It's not gonna get rid of the clot, but it's gonna stop the blood from sticking to that clot. Treatment, thrombolytics, I talked about that, okay, but here's some of the contraindications. You need to know these. That if somebody's had surgery, am I going to give them something that's going to bust up a clot?
No.
Probably not a good idea. Recent falls or spinal tap. That clot on the spinal cord or the spinal column, you break it open, they're going to leak fluid. Then you're going to have a whole other set of problems. It needs to be administered within 30 minutes of the arrival to the hospital. Now, your percutaneous intervention, door to balloon time is 90 minutes. Less than 90 minutes. That's how fast that muscle in that heart will be permanently damaged. And then if they cannot revasculate, whether they're getting the clot out by sucking it out from the catheter, or they're drilling or they do a little roto-rooter in there and break the clot up and then suck those pieces out because there's a lipid clot on the lining that's causing a bump, making the blood stick together. They'll then insert a stent, which will then make that open up and keep it open. Then they have to take meds for a long time to prevent more blood from. So, with your PCI, what we're going to do, this is your job as the nurse. You need to know what you need to do ahead of time and after a PCI. You have NPO for at least 6 to 8 hours so they don't vomit and then aspirate. We're going to take baseline vital signs, both sides. We're going to mark the pulses on the feet if they're going to go through the groin, or on the arm if they're going to go in through the radial artery. Mark it so the person who is following you can check the same exact spot for blood flow. Okay? We are going to tell the patient, anybody have a CT? They put that dye in you, do you feel like you gotta pee? Yeah. Or that you're peeing? But tell your patients this, because remember what they're saying because they give them meds. They aren't asleep. They're awake. But they're going to freak out on the table, and you don't want that happening when they're trying to insert something in the groin or in the arm in an artery, do you? Kind of warn them ahead of time. You're going to feel like you're peeing, but you're not. Afterwards, we're going to check the site where it's the size of a straw that they stick in that artery. You're going to assess that site, whether it's radial or in the groin, to see that it is not swelling. And if it's swelling, it's not getting hard because that's a lot of blood flow that clot may have popped off. And now they're bleeding underneath. You are checking it. Now, each individual hospital will have a certain protocol. You may be checking it every 15 minutes times 4. You may be checking it every 30 minutes times 4. You may be checking it every hour. You will have a certain protocol that you need to do. And each time you're going to check the site and check the blood flow. After the bed rest, we're going to get them up. They got to be in bed rest. Do you want somebody that had a straw in their groin sitting up? They're going to be laying flat. Are you going to give them a drink? Say, sit up, have a drink. You're going to go on the side of them and give them a straw. How about going to the bathroom? What are you going to do? Pure-wick. You can do pure-wick. If it's a guy, you can probably give him a urinal. But the pure-wick will work, yes. Don't sit them up. You will have protocols at how many hours you can put them at 20 degrees. At this many hours, you can put them at 30. At this many hours, you can put them at 45. And then you'll probably get orders to get them up and walk them around the room. Make sure they don't pass out. Okay. Finger foods, of course, you can't sit them up to eat, but there have been NPO all before this time. So they're going to be hungry. Get them food. And then once the bandage is removed, you make sure that the patient knows, you check in the site, sometimes they go home within hours afterwards. If there's nothing there, though, they have to be taught, educated, that they still need to keep an eye on that site and check it. And then discharge teaching, does it start after? You should, the minute they know they're going to the cath lab, you're going to be talking about it. Okay, collaborative interventions. We may need to have a pacemaker. If we've damaged enough muscle, the heart can't contract on its own, we're going to put a pacemaker in. Electrical conversion, maybe if they go into a hybrid, we'll learn more about that in a little bit, they'll cardiovert. Ablation, she talks more about that. If they've had a severe cardiac event and they go into shock, they may need an IAPD, we'll talk about that next week. Same thing with valvular surgery and transplant. We will cover all of these in the next lecture. And bypass or graft, again, if it has to be drawn past, we'll do a coronary artery bypass. We'll talk more about that next week. Stents, angioplasty, that's what they'll do if there's a clot. They can go in there and stretch that lipids and open up that blood flow. And then endocarditis, they're going to do the carotids. They'll go in and they'll open them up if they're not getting blood flow. Good. Okay, almost done. All right, here's your medications. Antihypertensives, arrhythmias, inotropes, I've talked about most of these, anti-anginals, vasopressors, and vasodilators. All of these are used will improve central circulation. And then for local, we got anticoagulants, thrombolytics, lower the lipids. We don't want making more clots underneath in the lining of the arteries. Vasodilators and antiplatelets, platelet inhibitors. Good. Prevention. Primary, secondary, collaborative. Make sure that you go through these. I'm not going to read these off to you. You can read them off. Know what they are, though, because who are you teaching the patient? So we may ask you questions about what are you teaching the patient. You better know which one you're going to teach. That's like what level that we're asking you the question, okay? Maybe before the PCI, maybe that you're out in the community, okay? That's it. Ooh. Record time. Boom. Bam!
I don't use one for
Hey, you want this?
That's all really much.
You want that? That's my favorite.
hope it's working. Straight up the stairs.
All right. We're gonna go right into this because this typically is a very long lecture, and we're not gonna have a lot of that time. However, you have a nom coming right before your test, right? So part of this lecture, we're gonna kind of trickle over into one of those stations so you can get the rest of this information. Because I don't want to go too fast and lose you guys, because it's kind of a big deal. Does that make sense? All right. So we talked about a lot of the anatomical parts of the heart and everything. We're going to do the electrical part of the heart. It's my favorite. I love scripts so much. So awesome. When do we need to know what our patient is doing on the monitor?
All the time.
Huh? But when are we doing that assessment? First thing, right? You got it's part of your whole head to toe before your 8 o'clock, whatever you put all that stuff in. You got to know what you're doing on the monitor so the physician doesn't come in and go, have they always been like this? So that's not a good thing. So it is part of your assessment. Please pay attention to that when you're in the clinical area too. You don't have to be proficient in there. Just know that the monitors aren't always correct when they tell you they're in sinus rhythm and it's a straight line. It's a machine. We're going to treat the patient, not the machine. Right? Right. So we're going to identify normal electricity. There's a PQRST that has nothing to do with pain in this particular level, right? Identify normal versus abnormal cardiac rhythms, and we'll go through different rhythms that start at the SA node and the AV node and through the ventricle system. And then understand basic terminology and identify emergency situations and appropriate status. I will tell you on testing, I don't think, I might have one or two, but generally what I do is I will give you a script. I'm not going to ask you to identify it. I'm going to ask you what are you going to do about it. Whether you don't need to do anything or you do need to do something. Because not only that, it tells me you know what that strip is, so you know what you're going to properly be doing for that patient. Does that make sense? So we're beyond identifying. You are climbing the Bloom's taxonomy pyramid. Okay. So, SA node. Normal rate is, people can't read it, right? I don't know. What's the normal heart rate?
67.
Okay. It is the normal pacemaker of the heart, and it is located just in the right atrium, okay? That sets the whole stage for everything. Hopefully, as long as that's good, we're all good. Okay. AV node. What is the normal rate for the AV node? 40 to 60. Okay. It is right above the lower part of right above the tricuspid valve, right in there. Okay. Takes those pulses from the SA node, goes through there, down, and delivers it into the ventricle, right? That whole ventricle system. Okay. Bundle of his, that's above. But when we start coming in here, down into the bundle of his and the Purkinje fibers, you have your bundle branch block, you have your right bundle branch, and you have your left bundle branch. And they can be blocked, one side or the other, right? You can have disruptions anywhere along the electrical system. You do not have to know bundle branch blocks. And I am not going to go over bundle branch blocks. Does that make it easy? Yes. Okay. However, if you start working on PCU units and ICU units, definitely needs to do classes to do that. But for NCLEX purposes, don't worry about it. We're not on the test. All right. But just know that you do have these two main electrical pathways, and the Purkinje fibers come off of that. I usually will refer to this whole system as like the ventricular node. So when you see when I draw pictures to make you understand, because some people are visual, that if I do an SA node and an AD node and a dot for the ventricle node, it's really that system. Does that make sense? Because I'm going to draw pictures. Okay. And then we just kind of talked about the Perfusion fibers that are throughout this muscle, and it's quite an elaborate system because your ventricles are like the thick muscle part of your heart, right? So it needs more than electrical. All right, so how do we get these electrical? I do have these. Look at that. How many, you've worked with patients on these, right? How many people have put them on the patient? Good. How many people have not? Don't be shy. What is this? I am not a this person. Okay, that's okay. So listen, there's 3 here. Where does the white one go? White on the right. Where does the black one go? Smoke over fire. Over fire. That's easy, right? Oh my gosh. I'm restrained. Okay. Okay, and then smoke over fire, and this goes down here. So these go just below the clavicle, and then this one will go down here. Okay? Every electrical pulse that goes from up here to down here is a positive deflection. That means everything is upright. If it's going the opposite way, and I'll show you a picture here in some of these EKG readings, you can have a negative deflection where it's upside down. Okay? All right. Is that all you see? See these? What about this? Holy crud. Now I got a brown and a green one too. So now what is it? Well, I know it's white over right and smoke over fire. Where's the brown or where's the green one go? Under the clouds. Ah, yeah, the green one goes under the clouds, right? And then where's the brown one go? Yeah, some people say chocolate in the middle where the heart is. Some people say something else. Some other brown stuff. Anyway, so you can see them on a 5. Okay? What is the difference between, do you think would be the difference between being on a 3 lead and being on a 5 lead? You'll see them on a 5 lead, right? So if you have a patient who's having like big time cardiac problems, would you put them on a 3 lead? Probably not. It's not that it's not going to be accurate, but if you're really considering that somebody's having a heart attack, you cannot see an anterior heart attack with this. You only see lateral or posterior. Okay? 5 lead will show you better. Okay? And then in the hospitals, you'll see this. It's the same thing. It's a 5 lead, but it's pink and it has that thing. But if you look at the top of these, they have the same colors, the white, the black, the red, the green, the brown. Okay? These are disposable, and they go with the patient wherever the patient goes, and when the patient goes home, they can keep it, or they can throw them away, or recycle them. I'm sorry, they could have a recyclation. That's kind of cool. All right. Okay. So, if you have an upward deflection, that is going from a negative to a positive, so this is a positive deflection. Does that make sense? We'll see negative deflections in other slides. Okay. This I just thought was really cute. You don't really have to do anything with this, but it just kind of shows the conduction through the heart in an animated form. So that this doesn't get boring. I can watch that all day. Okay, so what is your P wave? What's going on when you get a P wave?
Oh, Lindsay, you study. You study.
Atrial depolarization. Okay, what is the QRS? Ventricular depolarization. So then what's your T wave? repolarization. So
Relaxation.
where is your atrial repolarization? Your atrial repolarization is in your QRS.
Yes.
You will not see that because your ventricles are the strong part of the heart. That is the big, huge switch. So it's going to kind of overshadow, right? Okay. When we talk about normal heartbeat, this is one normal heartbeat, okay? One. This is one beat. Okay. PR interval is very, very important when we start talking about blocks. And today we may not get to blocks, and that's why I say we may be doing that in your next knock. That's for me to figure that one out. Okay? PR segment may also be delayed, and we'll talk about some of those problems. Your QRS is very, very important to know whether it is wide or narrow. And sometimes it will tell you where this is coming from exactly, because sometimes it's not normal. This could look like 12 different ways to Sunday. Okay? You don't need to know all of the reasons why, but we'll talk about some of that. ST segment from your last lecture that Professor DeWitt just did. Why is that important? Yeah, MI, right? So could they have an MI if this is depressed?
Yeah.
Sure. It's called a non-ST segment elevation MI, or a non-STEMI, right? So you actually can, and the lower this is, the worse off this patient can be. Like only 10% of it will survive. Okay. And then if this is way elevated, they come in, and you have 10 minutes to get that EKG. The state measures that. They look at everybody who comes in, and it's really a state measurement. And they say, okay, and you're doing it in 10 minutes, and they have an elevation. Where's the patient going? They're going right to the cath lab. They are not staying there for you to take blood. They're not staying there for you to do a CT. They are not staying there for you to get all their meds, although it's nice to know. They're not staying there for you to do all this stuff. They've got to get to the cath lab, because in the other lecture you saw time is tissue. Okay? Huh? Oh, okay. All right. So that's fine. QT interval is another thing that physicians will look at. We don't necessarily measure that, but it's important to know that sometimes medications will make this delayed. So a lot of psych meds sometimes make an elongated QT segment. Sometimes antibiotics do. And so physicians come in, they look at that, and they change medications around. You do not need to know QTs, but I just want you to be aware that that's there in medications. It dictates sometimes medication changes. Okay. All right. So heat wave. We already talked that it represents the depolarization of the atria, right? And it's part of that PR interval. And normal is it comes up from the isoelectric line. And the isoelectric line is straight across. You can make a nice little line there, right? And that becomes important because if you have ST depression or ST elevation, and maybe it's just a little bit and you're not sure, that's when we start getting into counting boxes, because if it's more than one box or two boxes, then you have a problem. And then as you start counting boxes, how high these ST segments are is how much worse damage you need to act. Okay, there's all the 50 million, whole bunch of QRSs you can have. This is like a bundle branch block, a right bundle branch block, so you don't have to know that. This is a left. Some of these other kind of weirdo things that go on. So this is your ventricular depolarization. Normal is 0.06 to 0.12. I think your book actually says 0.10. But if it's 0.112, you can consider that. And no, we're not going to say, is this normal 0.10 or 0.112? I promise. Okay? All right. your ST segment right there. The J point is this part that goes in, and you don't need to know J points, but what they're talking about is this is QRS, and before it gets to the T, that's what that is. But, oops, how in the world did that happen? Okay. So anyway, and then all this is down here, so this is all depressed, and you count boxes, so 1, 2, 3, 4, 5, this is a pretty significant non-STEM. Now, some people can have some ST depression that comes down through here, and it can be normal for them because they've had some kind of procedure or residual damage, and it's not affecting them anymore, so it will be probably post-procedural. Does that make sense? So damage is already done, they're not going to be 100% perfect, so sometimes you'll get, this is significant. It would be a lot less than that. This one right here, we will consider this an elevation. Here is your isoelectric line, and this is exactly one box above. So we do consider that elevated, and we do consider that that person's going to probably go to the cath lab. Okay? Okay. T-waves we look at. T-waves will tell us a lot, because if we see this peak T-wave where it's more than 2/3 the height of your QRS, there's a lot of things that actually can cause that, but this is probably what we're looking at mostly. Hyperkalemia, high potassium levels will cause that. Of course, in mice do. And then upside down ones, that's a deflection from here to here, right? Because from here to here, your T wave would be upright. Does that make sense? Mm-hmm. So if something's causing a backwards deflection, this can be, if this is hyperkalemia, this will be hypokalemia, right? So either way, you're going to be checking potassium levels, right? Really cardiac potassium, those two go pretty busy in the heat. Okay, EKG paper. We're going to do this really, really quick. How many people are in the UCF program as well? Okay, there's quite a bit of you. I'm going to tell you right now, UCF is a little bit more detailed in what they expect, because they will teach you, you have to count these boxes and stuff like that. I am not going to have you count boxes. For the test. Hold on a minute. So the thing about that is, if you see a strip on my test, you know, sometimes it just depends on if I can get a really good strip that shows up on the test really well. Sometimes they look like 3-second strips, but what I want you to do is I want you to assume every strip you see is 6 seconds. So if you have 4 QRS in 6 seconds, what's your heart rate? 40. Right? Because 6, there's 10 sixes in a minute, right? So 10 times 4 would be 40. Okay. So this right here, what would this heart rate be? 30. Technically, 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. This is really only like a 2.5 second thing. But if this was on my test, I'm going to tell you it's a 6 second one because it's just what it is. So this would be 30. So
if you continue to say, they will wipe the contact.
One big box here is 0.2 seconds, and 5 of these big boxes is 1 second, right? Correct? And one little box is 0.04 seconds. That's how you look at these boxes. But again, this and this, you do not have to count that for the test. But I do want you to know what this is, because if we're in clinical, I may be asking you this. The other thing is, every single clinical area has an EKG room, and I promise you, it will do you justice for testing purposes too. Go to the EKG room and talk to the people who work in there, because that's all they do. I can't imagine having a job for 12 hours. They sit in a chair and they look at like 60 people each on EKGs. And they're very good at it. You've had a lot of training, so if you have questions or you just go in there and say, hey, do you have anybody cool on the monitor doing anything? They'll show you, they'll tell you, they'll explain why it's a really good thing to do while you're in simple area. Okay? And it'll help you for the test too. Alright. This is just kind of the same thing. I told you these little boxes here. 15 boxes is 3 seconds. You also have these tick marks. I don't believe my strips have that. I know UCF does, and they tell you to look at these little tick marks. These tick marks are every 3 seconds. Okay. So that when you get in clinical, you know what they are. How do we get a rate? I don't even know what the heart rate is. What are we counting?
The QRS.
Okay, be more specific. What
The
letter?
ventricular
What letter?
depolarization.
R. We're counting R's, right? Okay. So we count R's. What happens if we have more P's than R's? What would the heart rate be? So we'll get into that, like if we have P, 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 QRS, P, P, QRS. How do we know what the heart rate is? It'll still be R. You'll have, they'll ask you for an atrial rate, but really the heart rate really is from the ventricle too, that would count, so it'll still be R, okay? Alright, so we're gonna look at this. We're gonna look at atrial, that has started. We'll look at atrial, we're looking at what's happening on our EKG, we look at the P waves, we want to see if they're rounded, we want to make sure they're smaller than your T waves, or they don't look like your T waves. We want to make sure that they're there, that there's one for every QRS, that it's decipherable, too fast, too slow, in shape. There's one where the waves look different every single time you have them. So we want to look at that. For ventricular activity, whether it's regular, irregular, if it comes early, if it's too fast, too slow. And sometimes, like in your other lecture, somebody is having heart failure, the voltage may be really low. So instead of having these QRSs, that are pretty decipherable, they may be like really, really little. Because the heart is not strong enough to put out the regular size EKGs that you see, so if they're kind of little, they may be having some kind of congestive heart failure. The PR interval is consistent. And again, we talk about that when we talk about blocks, which I don't want to get to. Oh, somebody loves me. Measurements. P waves. I got a coffee. I know. All right.
You'll know. I need to run coffee.
All right. Neural P interval. We talk about a PR interval. It starts at the beginning of the P wave and goes where the Q is. Okay. Normal PR. 0.12, 0.6. Probably a 0.2, we don't worry about it. If it's greater than 0.2, then we'll have a first degree block. Okay? So this is pretty normal. This is what we want to expect. Okay? Okay. QRS, this is the same picture that we had before. Your normal QT, well, we're not worried about QT interval. Let me tell you this. The normal QRS is probably about 0.04 to 0.12. Can't remember what your book says. 0.6 to 0.10, right? 0.12 is pretty normal. I wouldn't worry about a QRS being, I would still consider that narrow. 0.2. Once you get past 0.12, once you get past that, then you're looking at your QRS getting wider. Okay? And then this is for you, but we don't worry, and I'm not going to lecture regarding J points and U waves. Okay? But these are some of the measurement things that you will look at when you're deciphering EKG rhythms. But again, don't worry about this U wave here, and don't worry about this J point. That's just the J point coming up to the ST segment. It's this. Okay. Sinus rhythm. These are all sinus rhythms, right? Sinus rhythm just means it starts where? At the SA node. You can have normal sinus rhythm, sinus brady, sinus tach, sinus arrhythmia, sinus arrest. So we'll kind of look at those. Normal sinus rhythm, you told me that it was 60 to 100, right? Okay. I'm just going to find a thing in here. What is this rate?
70.
70! Good. And does it look good? Looks good, right? This is regular. Nice little P waves, smaller than the T waves, so I can tell the difference. It's kind of close together. It's within those 5 boxes. So that looks pretty good, right? So would you say this is normal?
Yes.
Okay, you're gonna throw in anything. This doesn't come later in the lecture, but I'm gonna say. This looks normal, so your patient is normal, right?
Yes.
What if you're looking on the monitor, this is what you see, and you say, okay, that's good, go on to the next person, and somebody comes in and says, this patient's dead. Could that happen?
Is it?
Somebody can say it really loud. Would that happen? Sure it can. What do we call that?
PEA.
PA! You're still giving off this electricity, but the patient's really not perfusing, it's really not doing anything. Okay, that was awesome. Fake 10 points to whoever yelled that out, that was great. Okay. Sinus bradycardia. Anything less than 60, right? What's the rate here? 40. Is there anything else wrong with this? He looks good. Less than 5 box. This is normal. He wait. Oh. Okay. There's always a QRS for every P wave, so we don't have to worry about having any kind of a block, right? So that looks pretty good. Do you worry about your patient?
Yes.
Okay.
It's coming from AV.
Okay.
Is it normal?
Could it be normal for them?
They're a athlete or
If
something.
they are an athlete, if they're an athlete, 40 might be normal for them.
Damn.
What else might they be sinus brady? What else may cause that?
Medication.
Medication. Oh, I took my beta blocker. No, I didn't. I'll just take another one. Oh, wait a minute. Did I take it again, or did I take it twice, or did I not? I'll just take another one. What's going to happen? Yeah, they're going to get really low, right? Okay. What else? What if they're hypothermic? That lowers down here, right? This is protecting your heart. So there's different reasons for having low pulse like that. So the best thing to do is to do what? Assess your patient. Yes. Yes, assess your patient. All right. I keep getting on the wrong buttons. All right. So this is what we said, right? Good athletic conditioning. If you go to sleep, increase vagal tone. I didn't talk about it. So increase vagal tone. What does that mean?
That is the person that the system is activated.
Yeah. What could have to that happen?
Why would that happen?
Yeah. Give me an example of that.
Straight along.
Bearing down.
So, in the hospital, one of the big things that happens to patients are they fall, right?
Yeah.
You're absolutely correct. So they can fall. So they go to the bathroom, and I don't know why they do this, and I don't know if you've had patients who do this, but they sit down on the toilet and they move all the way forward. Why do they do that? Is that normal or something? I don't know. I don't know. I'm just asking. But like all those little people that are so cute, they like lean over like they're trying to put their head get whatever. All right, some of the medications, Enderal, Digoxin, Verapamil, all these kind of blood pressure medications that lower heart rate will happen. You'll see Dig a lot. Dig interacts a lot with the electrical system in the heart. So you'll kind of see Dig toxicity happen quite a bit. Okay? All right. Hypothermia. They're usually asymptomatic. Somebody who's sleeping is not going to show symptoms except for when you're looking on the monitor. But if they're symptomatic, they can be short of breath, altered LOC. Why is this? Why is this? Why might they show all this stuff? Hypotension, CHF, fatigue, lightheadedness. Why? What's your concept? Increased perfusion, right? Some of you, I forget who was in what group or whatever, I said, what and most conditions would be like one of your first sign and symptom that you would see for decreased perfusion? Where is it? Right there. Don't get that oxygen to the brain, you're going to have problems thinking. Try and get your thoughts together, it's confused and gets worse and goes down. So, all of this is a perfusion problem, right? How are we going to treat it? Well, if they're asymptomatic, do we need to treat it? Why?
No, it is asymptomatic. I will treat it.
But if I write my advice, okay, listen, I just read this article, and this is even part of my lecture, but I'm going to tell you. I read this article that said there is this guy who is 81 years old. His normal pulse, because he's fit for 81, is 28, 26. I was like, what? Then he started talking about these athletes, these cyclists, like these huge athletes that are
You should be
just
sitting beside
probably
me.
have zero fat on their body, I guess. I would never know what that feels like. But anyway, you know, they're running and their pulses are in the 20s normally.
Wow.
Would I treat that?
No.
No, I don't need to treat that. Their stats are fine, their pressure's fine. I'd be kind of worried just because, wow. But yeah, I wouldn't treat that. Now, what if they start getting short of breath and dizzy and I don't feel so good and I'm going to throw up on your shoe? And what if they start having these symptoms? What are we going to do?
Treat.
Yeah. So we're going to go through our ABCs, right? So what are we going to do first? Airway. So we can sit them up, get them in a comfortable position, put some oxygen on them, right? We might need to start an IV on them, especially if they're really low. They're not used to that because we're going to be giving a drug. When I do this lecture, there's 3 drugs that we talk about that start with an A. So I want to make sure that you understand the 3 A drugs and don't make you mix them up. Your first one is atropine. Atropine is a drug that we give primarily, most of the time, for symptomatic bradycardia. Okay, that's what we're going to give that to. So they're going to get atropine. Do you think that could fix the problem? Maybe. Or if it doesn't? What if I give a dose of atropine and a little bit later they start going? Let's go ahead and give them another dose. Let's give them another dose first. But I like where you're going. Because that's probably what's going to happen, right? Because if you give a second dose, it's like, yeah, right, this is going to work. But we're going to try it. We're going to give them another dose of atropine.
If it's outdoor, I can.
We're going to go ahead and do that. Okay? That doesn't work. Now we're going to do this reinstatement spacing. In your head, we're thinking we're going to transcutaneous pace them, and they're probably going to get what? An internal pacemaker, right? So if there's a problem with the SA node, I don't know if you know a lot about pacemakers, but what kind of pacemaker do you think they're going to get? There's 3 kinds, atrial ventricular and an atrial ventricular. You're going to get an atrial, because that's where the problem is, right? Okay. Okay. Yeah. Anybody seen anybody get paced before? where you go like this. I did. Anybody do that? Okay, I did. Okay, okay. So this is what the pacers look like, right? You've seen these, right?
Yeah.
Oh, here's a good one. I better see everybody's hand. Who's the BLS? Yeah. Okay. If you didn't raise your hand, you're lying. Or you need to leave. All right. All right, these were in the AED, right? Remember the AED? So you know how to put these on, right?
Is that a
Yeah, exactly. Same thing. You're going to put these on, and we're going to control the rate for the patient. It's a little bit different than the AED, right? Because this is going to plug into that. Put these on. We're going to go over to the defibrillator, put it to pacing. And it's probably usually at a rate of 70 is what physicians like. It's controlled right, 70. And then you just start putting up the voltage until you get a sinus rhythm type thing. But you're going to have a little spike. Okay. Has anybody been peds before? You know what they look like? 70 times a minute. You think that would hurt? Yeah. So if you're a really super nice nurse, what would you do? Yeah, let's pre-medicate the patient. That would be really nice. Especially as I'm getting older, I hope it's me. I hope it's me that you all give me medication. I got you. That you all give me medication for and some Xanax because it really looks like it hurts. Okay? All right. So that's what's going to happen. And then in about 10 minutes, I'll continue. So maybe do a 2-minute break. Right now. So you think about.
Okay.
Yeah.
I think so. Then you go pause.
All right. Sinus time. What do we call that? The rate is greater than
100.
Okay, when we go through this lecture, I'm going to tell you there are 3 tachycardias. Okay? First one is sinus tach, which is greater than 100, less than 150. Okay? So this is your first one. What's the rate there? 110. Okay. So you now have somebody who is 110. Do we worry about that? Do we worry if they're 120?
Yep.
Yes, no? How many people think we worry about 120? How many people think we don't worry about 120? How many people want to assess our patient first? All right. What causes someone to be tachycardic?
Exercise.
Everything under the sun. You know what the number 1 reason for tachycardia is?
Stress.
Nursing students. Nursing students and exams. That's right. That's number 1. That's on the test. You know, I'm just kidding.
You can
This
put
is
that on the
sinus
test. We'll all
tach,
get it
and
right.
even though the heart rate can be up to 150, you will always still have, or should have, QRST, P, QRST, P, or TP. That is that little peak thing. That's your P wave, QRS. Big peak is T, little is P, QRS. So you have a P wave for every QRS. It's sinus tach. And it is regular, right? Your beats are regular. What are we going to do for it?
Slow it down.
What are we going to do for tachycardia? First, before we do intervention, we do what?
Assessment.
We assess them, and then what's the second step?
Intervention.
Figure out what the problem is. Because if it's me and I'm walking back and forth because I can't seem to sit in a chair, like Professor DeWitt and everybody else who lectures in here, my heart rate is probably the same thing. However, if you have a patient who's been in bed and their heart rate has been 70 and they have this big wound and now they're 120, what are we going to worry about? Infection. So then we're going to kind of follow up on that and take care of that. So whatever the reason that somebody's tachycardia has this high heart rate, we're going to look at why they have that and fix the problem, right? Does that make sense? Yeah, okay. All right. Which is what here? Fever, pain, anxiety, CHF, MI infection, hypovolemia, right? Because it's compensatory that we would raise our dehydration. These are all perfusion problems, right? Exercise, nicotine, yeah. And sometimes when we talk about drugs, I think on the other ones they get kind of a little bit more vague and say drugs. It's not just drugs that are prescribed, right? It covers street drugs too. So street drugs are really horrible too. When we talk about cocaine, I had a 23-year-old who had 5 heart attacks by type straight 3 because he's doing cocaine. He come in with that elevated ST segment, go right to the capillaries. I don't even know if he's around anymore. He's still probably young. Anyway, dopamine, atropine. So we can actually cause somebody to have a high heart rate, right? They were in symptomatic bradycardia, so we just gave them a bunch of atropine and now they're 120. Are we going to treat it? No. We caused it. It's better than being symptomatic bradycardia, but that's okay. That means that drug is working. And if it's 120, it's 120. It'll come down and the drug goes off as long as they're stable and they're not having problems, right? Okay. If they're asymptomatic, we're not going to do anything about it. If they're symptomatic, then that's what they can have. Chest pain, shortness of breath, just not feeling good, nausea, vomiting, all those general poor perfusion type symptoms, right? And we're going to correct them by the boss. Sinus arrhythmia, we don't really talk a lot about that, but can you see? We have PQRST, 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 PQRST. Is that bad?
Yes.
What is that? That's probably me like right now. So when I walk across here, this is me right here, and then I stop on the corner here and start asking you questions, and my heart rate kind of slows down, right? All of us are probably doing this. It's asymptomatic. We don't treat it. It's just if you go, oh, my heart's kind of like a regular, but you don't feel any different. That's why. Sometimes it does this when you're breathing a little heavier or whatever. Most people don't know that happens to them. Okay? So it says usually seen in the young and elderly. I just laugh. It's in everybody. Okay? It's in everybody. No real big deal symptoms. Not doing anything. Sinus rest. The reason I put this one up here is because if your patient, this is going to be like an SBAR type thing that I'm bringing this up for, okay? But what can happen is the SA node, so you got PQRST, 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 and then this SA node goes, but I'm so tired, I'm not going to do anything right now. So it doesn't, right? And then somewhere else in the heart's like, I'll be the SA node, and so they kind of take it back up into the SA node and just kind of naturally takes over, right? But what we're talking about is this right here, is this pause, and it can be 2 seconds or greater, okay? But that's what happens. It's just like, there's just a delay in the SA node going, that's like a beat again, I'm just tired of beat. And a lot of times in patients, you won't just see just one of these, you'll see several of them. And some of them, I had a student give me these long strips, and most of it was that. And I'm like, wow, I hope somebody called the physician. So this is what you do, okay? if this was me, I'm calling a physician, right? Okay, so this one happens to be 1, 2, 3, 4, 5, that's 1 second. 2, 3, 4, 2 seconds, okay? Hey, Dr. Smith, I'm calling you about this, about the patient, Mr. So-and-so, are you familiar with this patient? Well, he's having some sinus pauses. So he just had a 2-second pause, and 3 minutes ago it was a 5-second pause, and 5 minutes ago it was a 3-minute pause. So he's having these frequent pauses. Okay? That's what that is. Why does that happen? It could be a multitude of things. Oop, I guess I don't have the multitude of things up there. But it can be from beta blockers. It could be from different medications. It could be the start of some sick sinus syndrome if your peak waves are not looking normal. So where this isn't necessarily a test, but I want you to be aware of it in the clinical area because I stopped teaching it and because we don't see it a lot when we were out in the clinicals, and then when my student came with all those strips, I'm like, wow, I want you to find this and bring it because it's really interesting. It's only good at EKG and that's what they have. But that's what it is. It's just kind of like this pause thing. Sometimes they do not have symptoms. Sometimes they will have the symptoms of non-perfusion. They may feel dizzy. They may feel, so it will become a safety issue to make sure that you're not running them around in the hallways and things like that. So then we go on to atrial rhythms. We're going to talk about premature atrial contraction, SVT. We can brush over atrial tachycardia. AFib is huge, A-flutter is huge, wondering if you're a pacemaker, I'm not really concerned about. But I do want you to know that there are 3 premature complexes. And I can't write for anything, sorry. Your first one is this PAC. Okay? And I'll tell you right now, this is, I don't draw either, okay? So here's your SA node, here's your AV node, and remember your bundle of hits and everything, I just call it your ventricular node, okay? These are each going to be your premature complexes. Right now we're talking about if this fires early. If your SA node fires early, you're going to have a premature atrial contraction, okay? Premature atrial contraction looks like this. You're looking at a sinus rhythm, and you go, okay, 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 okay. Ooh, that's an early beat. You see how that's early? This one comes a little bit early, and there's a P wave right there. So this is started by the sign from the SA node. So this is a premature atrial contraction. So that's what it is. Otherwise, it's sinus rhythm with 1 PAC. Does that make sense? So when you have a strip, you should see regular, 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 and this should really kind of be right there, but it's right here. Those are the things to kind of look for in a strip. All right. Guess what? Most of us have these, and we don't know it. So, or sometimes you might say, oh, I feel like I skipped a beat or something like that. It could have been this, but we're never going to know that a lot of times they're transient and they're so fast you don't pick it on the EKG unless you're on them for a long time. Okay. This is your second tachycardia. The other 2 tachycardias are greater than 150. These are greater than 150. That's a letter, man. What am I doing? Okay, so this is atrial tachycardia, okay? And it does have a P wave. So you see how this is? What's this rate? Huh? 180, right? Okay, greater than 150. And the reason that this is an atrial tachycardia is because you still have that P wave right there. See? But it's greater than 150. So your SA node is really going. Okay. Rate can be 150 to 250. they're gonna be symptomatic? Yeah, so we wanna get this down, right? Wow, that's funny to hear. So we're gonna have to get this down, whether we're gonna be giving them medications. Now, if they're ever gonna be symptomatic, which they probably are, what kind of symptoms do you think they're gonna have? Do they have time to fill up the heart and perfuse everything? No, so they're gonna have perfusion, all those perfusion symptoms we talked about, right? So they could be short of breath, they could be dizzy. Their cardiovascular assessment, maybe they might be a little bit pale, maybe they would be cool to the touch. Depends on how long they've been like that or what's going on with them. So we may need to give some kind of medication to slow down their heart rate. And probably if they're symptomatic, it's going to be through their IV because it works faster too, right? So not PO, we'll probably give it IV. Okay. Here is your third tachycardia. It's my favorite in the whole wide world. So this is your third one, is SVT. And it is still greater than 150, except there's no P wave. God, I really write it terrible. Okay, so there's no P wave in this, right? Your QRST, 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 QRST. Rate still can be 150 to 250. Can I be asymptomatic with this?
Yes.
You can. I have a lady who comes in sometimes and she goes, hey, I'm having SVT, and so I need that medicine. She does. And she kind of knows. She's like, I just, she monitors heart rate, and anyway, she comes in. It's weird. But I'm an ER nurse, so that's why I'm telling that story. All right, so you cannot see a P wave in there. Sometimes it goes so fast. So what do we do for that? Somebody comes in, they're in SVT. One of the things we would do is increase vagal tone. Remember, vagal tone will bring down and cause bradycardia sometimes. Well, if they're asymptomatic, or they might just be a little short of breath, but they can walk or whatever, they'll start small. So we're going to make them bear down, right? So we make them bear down. You can do that. You can have them, blow on their thumb. Remember when you first started doing incentive spirometer and you blew into it and couldn't get air to go anywhere and thought that was right? So you can take an incentive spirometer, have it blow into it. That will help. Anything that will increase pressure through here as well. So if that does not work, then what we could do is give your second A drug. Does anybody know what that is? Adenosine. Right? We're going to give adenosine. What does adenosine do? Okay, what are you going to educate the patient? Please do not tell them you are going to start stopping heart. Because I'm going to tell you no. I will take my sweaty self that can't hardly walk home. Yeah, don't tell them that you're going to stop their heart, which is really hard. Okay, so we're going to give adenosine. I want to tell you, when we give this medication, that's what exactly happens. It resets the heart. That's what we're going to tell the patient. Hey, we're going to reset your heart. This medication works so that it'll slow your heart down and put it in a regular rhythm. That's what we're going to do. You might feel a little funny in the chest. No, actually, you feel like boom, but we're not going to tell them that either. Okay? All right. So we give that adenosine. Physician has to be there. They have to be on the monitor. They have to be on the defibrillator. They have to have 2 huge IVs in. This is a big deal. Because we're stopping their heart. Right? RT would be really nice to be there. Maybe a backup nurse. So you have a big team there when this happens for one drug. Now, here, let me tell you about adenosine. Adenosine, you're going to give 6 milligrams for your first dose. Not that you need to know that, but we'll give 6 milligrams. By the time you give it, till it gets to the heart, it's probably gone. It has the half-life of a gnat. Okay? It gets eaten up very, very, very quickly. So you have to have a big IV in. Central line would be better, but if they don't have that, whatever. And they have in the hospitals, they have a bifurcated IV, and you could put the medicine on one and a 20 cc flush on the other, because you've got to go boom, boom to get that all the way to the heart. Because if you only get the medicine, it's going to stay in the line, right? So you go boom, boom, and give that, and hopefully it works. If it doesn't, you can give a second dose of 12 milligrams. Okay? And then what you should see is, you see this, and then you'll see, and it can go out to 6 seconds, and you're like sweating bullets. And then hopefully it goes back into normal cycle rhythm. Okay? If it doesn't work, you can get that second dose. And you're going to write, because you have them on the defibrillator and you have the strip coming out continuously. When you see that long line, just write adenosine. So that you know when that happened, all right? You're working with what's going to happen. All right. What happens if that medicine doesn't work? And they're starting to get really symptomatic. We're going to give electricity. So we do something really easy, then we do meds, and if they're really symptomatic, we're going to give them electricity. So what are we going to do? Are we going to defibrillate them or cardiovert them?
Cardiovert.
We are going to cardiovert them. Who do we defibrillate?
VTAC, VFib.
Dead people. You defibrillate people who don't have a pulse. Dead people. New dead people, old dead people, dead people. Okay. Right. Pulseless VTAC and VFib. That's it. Everybody else with cardiovert. Okay. So cardiovert. Okay, so what they do is they put it on and on cardiovert, and it's different. When you shock somebody, you just push that button. But when you cardiovert something, you push the shock button and hold it, because it's looking for those R's. So you got to help it look for those R's. So you hold the button until then it'll shock and you can let go. Does that make sense? Good. All right. SVT. What causes it? Do you see anything on there we haven't talked about yet, except for maybe some of these diseases that you get from birth, or defects or things like that can happen. History of stress, nicotine, heavy duty slicing, caffeine off of everything. No, I'm just kidding. Caffeine does, they can feel racing of the heart, anxious, and then if it gets worse, they're going to have all those poor perfusion symptoms. I already told you O2, make sure you get that IV into them, vagal them. If they become unstable, if they're unstable but they're lightly, it's kind of, if they're just like short of breath and they're like they can feel it, you may want to try the adenosine. But if they are really asymptomatic and their pressure is low and things like that, we're just going to go right to the electricity. Okay? If they are very unstable, you just go right to electricity. If they're unstable, you go to electricity. Okay? AFib. Oh my gosh, how many people have you seen in AFib? Like 20-some% of people are in AFib. 25 people? All right, so AFib, we have P waves. Is your atrium pumping proficiently? No, it is not doing this. It is doing this. It is doing first metal stuff. It is just fibrillating. It is not pumping. Is that efficient? What do we worry about? Not just stroke, we worry about blood clots, right? And the reason stroke is a big deal is because it's just so close to the brain. But no clot comes out of here and says, I think I'm going to go to the brain and cause a stroke. It could be anywhere, right? I just want you to know that. You can get DVTs, you can have MIs, you can have a whole bunch of stuff. Okay, what happens when it fibrillates, you have blood pooling right here on both sides. mucosa goes through, and that's how you get the blood clot. That's why they're so worried about that. So what are they gonna go home on? Yeah, they're gonna go home, right? Okay. So, when we look at the actual strip, this is not any P waves. Don't find P waves that are not there. If you don't have a discernible P wave or anything, and your QRS is irregular, it changes. Short, time in between. That's very, very irregular. You know why? Because the ventricle goes, okay, I don't know when to go, because it didn't pump to tell me to go. I'm not sure when to go. I think I'll go down. I think I'll go down. I think I'll go down. Now. I think I'll go now. It doesn't know when to really go because it's not proficient. Make sense? Can people live like that? Sure they can. There's a lot of people walking around with it there. They're probably on those medications though. They're going to be on blood thinners. Okay, what else would they be on? Because if this QRS doesn't know when to go, it could go 120. So how are we going to control that? They may be on beta blockers when they go home, right? Now, if their ventricular rate is really high while in the hospital, a lot of times they'll start them out on calcium channel blockers, like Perfusion. I'm not supposed to say Perfusion. Thanks. I always mess that one up. So Perfusion is just easier. They'll give that IV to control the rate, the ventricular rate, get it down to where it needs to be, and then once that's done, they go on the calcium channel blocker, beta blocker. Okay. Symptoms. A lot of times they're asymptomatic. A lot of people live with it. That's what's happening. It's just firing from all over the place, and it just makes it fibrillate. They can have palpitations, weakness, dizziness. Depends on symptoms. If they're stable, that's what I said. They may be on calcium channel blockers or beta blockers. If they're unstable, urticardioversion. Why are we not defibrillating them? Because they have a pulse. They're not dead. Okay. Good. We can synchronize cardioversion. A lot of times they're very, very cautious if somebody has been in AFib chronically to do that because they can release blood clots. So they really want to make sure that that's kind of like a newer type thing. I'm not saying they're not going to do it on a chronic, but they're very cautious about that. Okay. Huh? Least invasive means of control, absolutely. Okay. A-flutter. We treat A-flutter a lot like we do AFib, but it's very different because you actually do have your atria squishing too proficiently, right? So, each one of these, you will not see a P wave because your SA node is just going off. These are all P waves. P, 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 P. So this may be a 3-to-1, this is a 4-to-1 conduction, you can have a 2-to-1, and it can change. So your P wave is always regular. Always regular. Your QRS may not be. It could be, but it doesn't have to be. Because what's happening, I'm going to use this part over here that I did. It's right in green. What's happening is it starts at the SA node, and it goes around and around and hits the AV node. Around and around, hits the AV node. That's what's happening. It's just a cycle. And it just depends which time in the cycle it hits that AV node to squish the ventricle. Does that make sense? Does that make sense? So, P wave, P wave, P wave, hits this QRS. P wave, P wave, P wave, QRS. P wave. You see that? Okay. doing a lot of strips. I have a big strip packet, you can work together, you guys can email, call me, it's a big deal. It's a lot, I know. Okay. The rate can be this high. And guess what? They're gonna have problems with perfusion, right? Because your atria is just putting out whatever is in there, and it can hardly fill up before it starts putting it into the ventricle. So you're gonna have poor perfusion symptoms, right? Okay. And this, by the way, is also called sawtooth. It kind of looks like a sawtooth. So sometimes you'll see the P wave being referred to as like a sawtooth pattern. Your PR interval is unmeasurable, just is. Your QRS is usually narrow. There's not really that problem, and you're not going to have a QT because there's no G. Okay, what are we going to do with this? Some people are asymptomatic. Some people go into flutter, and then they'll have fibrillation. And then they'll have flutter, and then they'll have fibrillation. So some people kind of can go in and out of both. Kind of weird. Okay, but palpitations, weak, dizzy, sorry about that. And it depends on the symptoms, whatever they have is what you're going to treat. If you have a ventricular rate of 130, 140, we go back to the same way we do for AFib. You're going to be given a calcium channel blocker. Usually that's IV to begin with. And then they'll go home on beta blockers, or we can cardio them because they're not. Wandering atrial pacemaker, I don't even really care that you know this, it's not even on the test. But what that means is when you see this pacemaker, what I want you to know is this is not a mechanical pacemaker, this is the normal pacemaker of the heart. So when it's wandering and the atrium is just coming from different places, and your P waves look very different. That one's a 10, this one's upside down, that one's kind of normal. You might have a flat one that hardly looks like it's there. If you have all these different P waves, that's what this is. Most of the people don't really have it. So, and the rate is usually normal, and you need to make sure that you're looking at different leads to make sure that that's correct. AV, these are junctional rhythms. So these are rhythms that are going to start right here, right? This is all junctional because it's the junction between your atria and your ventricle. If that makes sense, right? Okay. So we have a junctional rhythm, premature junctional contractions. That is your second one. So of your premature complexes, you have, I don't have my red one. You have a PJC. Okay? That's your second one. And I'll show you that one. Okay, so this is a junctional rhythm. What's going to happen is it originates right there. Okay? So what is your rate going to be if that takes over? 40 to 60. If it's over 60, it could be accelerated junctional, but generally it's going to be 40 to 60. Okay? Two things can happen with your P wave to know that it's junctional. Since it's not coming from the SA node, this top one, you're not going to get that squish P positive deflection. Because what's going to happen is if you have a P wave that starts here, your P wave is like that, right? But if there's some kind of disruption or block here, and this takes over, it's going this way, the opposite way. So what's your P wave gonna look like? It's gonna be upside down. Does that make sense? So if you have a junctional rhythm and there is a P wave, it's gonna be upside down. Otherwise, or also, if you ever see a rhythm and the P wave is upside down, it's always, always, always a junctional rhythm or a junctional beat. Always, because there's nowhere else it's going to come from. If the block is right above this AV node, conduction, there, it can't get through there. So you can also have no P wave if it's junctional. Does that make sense? Depends on where the block in electricity is. If the block is lower, you might not have a P wave. So let's look at that. Up here, this P wave is upside down. This P wave is upside down, and that P wave is upside down. Don't look at this, that's not a P wave. This is. This is. This is. Okay? Looks better down here. That's an upside down P, upside down P. This is junctional. This is accelerated junctional, because what's the rate? 70. But you just told me that the rate for an AV node is 40 to 60. So if this is 70, that P wave upside down is junctional, so it will be an accelerated rate. Okay, kind of like junctional tachycardia. Okay? All right. So here, if we look at this, you have PQRS. I think there's a T in there somewhere. PQRS, PQRC, PQRC. This one looks early, right? Because this is all regular, 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 regular. It should be here, but it's early. But there's no P wave. So it cannot be a premature atrial because it didn't come from the SA node, right? And your QRS is narrow. So it has to come from the AV node because it's narrow. That'll make a difference when you do PVCs. How many people are with their head right now? We have 4 opportunities to go over all this stuff. It's okay. And I have a whole packet for you to practice on. I'll give you the answers, and it's okay. But with junctional, that's junctional tachycardia. We won't worry about that. Don't worry about that. Okay. Sorry. All right. So on the bottom part, regular, 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 regular. There's PQRST, PQRST, PQRST. This one is early. It should be right here. So this is an early B, and your P wave is upside down. Right there's your P wave. Not the one up against it, this one right here. As you see, this P wave is not up against this QRS, and this P wave is not up against this QRS. That's why this is not your P wave. This is. Does that make sense? Okay. This one does not have a P wave. Narrow QRS, junctional. This one has a P wave, but it's upside down. Narrow QRS, junctional. Do you get it? Okay. All right. I'm not going to worry about junctional tachycardia or the escape. And we're going to go through the blocks because I told you I would do that later. Okay, let's do ventricular rhythms. Okay? Because we already did atrial, we already did junctional, so now we're going to go to the bottom. Make sense? Okay, yes it does. So we're going to do PVCs. That is your third premature complex. Premature ventricular complex, right? So you have PACP, JCP, VC. Does that make sense? One for each early beat. Okay. VTAC, VFib, idioventricular asystole. We are not doing W-branch blocks. And PEA, which kind of brought that up. Okay. PVC. Sometimes if they go to cardiac procedures or they're taking in caffeine or there's some kind of irritant to the heart, you can have PVCs. Okay? It is your early beat, it is your early complex, and the way that you know the difference is it is wide. The QRS is wide. Because it's coming from the bottom of the heart. Okay? Anything that starts from the bottom of the heart is going to be blind, because that's what's going to be taking over. Rate varies, it doesn't matter. You can have frequent PVCs, you can have occasional PVCs. Some people have PVCs and don't know it. However, if they're in a procedure and they start having PVCs that they didn't have before, what do you think you should do? I would call them. Yes. Even if they're not symptomatic, if they've not been having a lot of PVCs and they go for a procedure and they come back and they're having PVCs all over the place, I would just let somebody know that. Maybe they do know that, hopefully they told you that before or something, but I would get on the phone with the doctor and just say, listen, and quantify it, because they're gonna, if you just say, hey, they're having low PVCs, what does that mean? But if you say they're having 9 PVCs a minute, or 6 every half hour, whatever, you know, you gotta quantify everything that when you call them. Make sense? Okay. What causes them? Sometimes it's a normal thing that just kind of happens because of what we do. Anxiety, nursing student, exercise, hypoxia. There's that ditch, right? Acid-base imbalance, which when we go into concepts for acid-base imbalance, you'll see why. Other times it has to do with potassium too, right? Because that's what helps your heart do what it does. Having an MI, CHF, caffeine, tobacco. Here are your electrolytes. They can be mostly symptomatic. Most people are asymptomatic with it. But you may feel palpitations, get beats. I mean, if it was really severe and you were having them very often, then you're going to get those same non-perfusion, poor perfusion symptoms. I feel tired. I feel this. I feel just weak. I'm short of breath. Those type of symptoms. How are we going to treat them? Usually, if they're asymptomatic, we're not going to do too much about it. But if they are, they will put them on medications such as calcium channel blockers and beta blockers. If it's really bad, especially maybe after a procedure, they may put them on amiodarone or procainamide. Amiodarone is your third A word, right? Your third A medication, and it's for dysrhythmias in the ventricle. Where we mostly use that. Okay? All right, so PVC, pretty obvious to find it, isn't it? You see it? Didn't hide very well. Here's your PVC. See how that's all wide and yucky? And this one? Is there any difference in between this? No, it just depends on where it comes out of in the ventricle. It can come from anywhere, so they can look very different. Okay? But that's your PVC. Now, if you're having quite a few, look at this. There's your PQRST, and then you have a PVC. PQRST and PVC. PQRST and PVC. That's every other one. We call that bigeminy. If it's every third beat, it's trigeminy. If it's every four, it's quadgeminy. I think we stopped there. But anyway, if you look at these, this looks just like this, looks just like this. We call those unifocal because they look just the same in the same strip. Does that make sense? If they look the same in the same strip, we call those unifocal. Now, if this happened and then this happened in the same strip, we call that multifocal because it's coming from two different places within the ventricle. So we have unifocal and multifocal. And here's an example of that. Here's unifocal, which is just the same, right? And then here's not, these look totally different. Okay. Guess what? Sometimes they happen right on top of each other. So they call it a couplet. And that's unifocal because they look the same, unifocal couplet. These look totally different, they're multifocal, they're coming from two different places within that ventricle. Is anybody lost? One person raised their hand, they were like, no, I don't even have the strength to raise my hand anymore. All right. When we talk about these ventricle things, you're talking about your progress. Remember when we talk about the field, you're talking about your PWA. When we talk about junctional, right, you're talking about right before QRS. So that's why these strips are the way they are. And actually what I think I'll do, I might release, I think I'll go ahead, well, your ticket in has to do with strip packet. So what I'll do is after tonight, I'll go ahead and release the packet so you can look at it and practice it along with this lecture and just keep practicing and practicing so that you can understand if that makes sense. And remember, you can always text me if you have questions about stuff. And also, some people get into groups. I don't know if you guys have study groups for this, because this is a hard concept. But some people who are really good at this, because there are some of you who are following along, I can see, in the groups, and you find there's people, and it really, really works out very well. But please come to me if you have questions after you're working on your scripts. Please come, when you're done with the whole script packet, I have the answers. Cheating, I have the answers. All right. Look at this. These are all PVCs, right? Because they're at the ventricular level, they're QRSs, and they're wide. If you have more than 3 in a row, this is actually a VTAC. It becomes a ventricular tachycardia, even though it's like 6 of them, 1, 2, 3, 4, 5, 6. So if I was to call a physician, I would actually tell them, this patient, I'm calling you because they've had a run of 6 VTAC instead of 6 PVCs. After 3, they're just counting them as VTAC. Does that make sense? The ventricle is just now just going off. And then it goes into a normal rhythm and then it can just go off. It's not just like 1 or 2. Does that make sense? Okay. Okay. And then this, what is this? That is VTAC. That's all your ventricle. That's all it's doing. It's just pumping, 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 overriding everything else. This is VTAC. If a patient is in VTAC, can I be talking and asking for a sandwich? Huh? Yeah. I can. Freaky thing, because it scares me to death when people do stuff like that. They can't. They cannot realize in the early stages that they are in VTAC. Because this VTAC, is that really good perfusion? No. It's dumping everything as quickly as possible, and then they can't even fill up to keep up. So eventually, they're going to start. Somebody's going to start decompensating. They're in this rhythm. But I did have a patient. He's like, I don't feel anything. I just want to eat. Well, guess what? I want to eat because I feel like I'm going to keep doing CPR and I want to aspirate. So we'll talk about what we're going to do with that. But that's what VTAC is. So what causes VTAC? A lot of times it's a precursor or right before right when they're having an MI. It could be from untreated PVCs. So if they come back from procedure and they have a lot of PVCs and nobody's doing anything about it, they can go into VTAC, right? So sometimes we do that. Acid base imbalances, aneurysms, stimulants, and then you have your electrolytes. An ROT phenomenon, a lot of times, I'm not going to go too much into that, that's not on your test, but a lot of times that will have to do with if they have pacemakers. And the pacemaker doesn't fire when it's supposed to, and it fires on the R of the QRT, it could throw them into VTAC. But we're not gonna talk about that. Don't write that down. All right. Symptoms, they can have palpitations, feel dizzy, chest pain, short breath, same things, right? The same symptoms of non-core perfusion. Core perfusion. So if they're stable, of course we're gonna put them on O2. And here's your, remember I told you, this is your ventricular dysrhythmic medication, amiodarone. It's to get them out of these lethal rhythms, right? So we're gonna give them a bolus of amiodarone. Okay? If they're unstable, you're gonna cardiogroup them? Yes.
I was just wondering if there are, like, if any of the dysrhythmias have, like, really specific symptoms that are different from all the other ones. It seems like they all are basically having the same symptoms. But I was wondering if
A lot of times they will have the same symptoms because they're all perfusion symptoms. Because that's what the heart's doing, is perfusing, right?
yeah.
These are all just different, problems that cause the perfusion problems, that it will have very similar symptoms. What you're asking is how are you gonna know the difference if they're having the same symptoms, and what would be your answer?
Just the ECGs, only with
You're gonna put them on an EKG, absolutely. And we're not gonna put them on a 3 lead, because then you can't see anterior. You're not gonna put them on a 5 lead. You're gonna put them on a 12 lead, and you're gonna see it 12 different ways. Okay? Because sometimes things that we see, we need to confirm it in different leads, especially if they're having an MI. You can tell where that MI is on a 12 lead based on what leads have the problem. So, yeah. So, in general, yes, they could have all the same type of symptoms and they're symptomatic, because it's the concept, it's a perfusion problem. Yep, absolutely, that's a great question though. Okay, so we're gonna cardio work these people, if they're alive. What if they don't have a pulse and let me go back, and they look like this? What if they don't have a pulse? What are we gonna do with them? We're gonna defibrillate them, because they don't have a pulse. That's pulseless feedback, we're gonna defibrillate them. Okay? All right, well, there's your pulseless feedback right there. Same causes. If we do not save them when they have a pulse in VTAC, and then they lose the pulse, that's how we get to pulseless VTAC. It's just failure to do anything to get that pulse. Keep that pulse. Same things cause, right? You're saying, well, your symptoms, you don't have a pulse, so you're not going to be complaining of much, right? But we already know you're not perfusing if you don't have a pulse. You're still going to have the O2, you're going to call your code team. We're going to defibrillate them. National standard for defibrillation, once it's recognized, is under, does anybody know? Under 2 minutes. Didn't you learn that in CPR? You do a little back, would you like to defibrillate them under 2 minutes? Okay, under 2 minutes. As soon as you see it happen, it'll be really, really good. Nurses tend to delay because they're afraid of electricity. They're afraid to defibrillate because they want to wait for a physician. If you have your ACLS, because you work in that type of area, you can defibrillate them. You are trained, you have your certificate. That's what it's for. Okay? Just make sure they're not sleeping before they do it. That will be bad. I had somebody do that one time. They thought somebody was flatlining, and so they run in there and they're starting to do compressions, and the guy got all mad. And it just turned out that one of his leads came on. So that's why I say, before you go run and do anything, just assess your patient. All right. All right, so we're going to even if they don't have a pulse, you're still going to give amiodarone. The amiodarone we give life, you have 150. You don't have to know that. I don't think that's in there, but I'm just telling you. But we still defibrillate. Okay, VFib. Do they have a pulse? In VFib, do you see anything organized on there that they would have a pulse? No. Are we going to cardiovert or defibrillate them? We're defibrillating them. They are not alive. Okay, they still have a little electrical activity in their heart, but they're not alive. All right, clinically. All right, so this is just the same thing we talked about AFib and atria doing this. Now this atria is not even working, and you have a ventricular or a ventricle that's just in there. That's where we are. And pretty soon that light goes out too. All right, you can have coarse, which looks like VTAC, doesn't it? Okay, so if you have this and you're like, hey, this is VTAC, and someone says, no, it's coarse VFib, you can confirm that doing what? Getting your 12 lead. Okay, because sometimes it might look different than me. But do we treat it different if they don't have a pulse? No. Pulseless VTAC and VFib we treat just the same. So are we going to haggle over whether this is VTAC or VFib if they don't have a pulse? No. They get amiodarone and you defibrillate them. Okay. All right. So what causes VFib? If we fail to rescue them when they have those PVCs into VTAC, into pulseless VTAC, and now they have VFib, right? You can probably, I've seen this happen when you have somebody who come in who is lightning struck or some kind of electrocution can happen because that's really going to mess up the heart. I mean, you know, you think if we defibrillate with 200 joules, if they get struck by lightning with 10,000 joules, it's kind of totally different. So that can actually stop their heart, so it can cause this. Okay? MIs, DIG, toxicity, and then we're back to potassium problems, no cardiac output, no pulse, no BP, loss of consciousness. They're not going to say they're short of breath because they're dead. CPR, defibrillate them ASAP, right? Intubate and give them medications. They're probably going to get that A word, right? Because it's ventricular, they can get amiodarone. The other medication that they can use is lidocaine, which is kind of making a comeback because they're antidysrhythmics. So you can give lidocaine or you can give amiodarone. They're really kind of big on amiodarone right now. But the thing to know is, if I bolus you with amiodarone, because what they do is they'll bolus and then they'll hang it as a drip. So if I bolus amiodarone, I'm not going to hang lidocaine as a drip. You stay with what you start with. Does that make sense? Why would you change, switch over? Okay, so it could be either one, but it tends to be amiodarone right now. Ooh, look at that, isn't that pretty? The dudes already have one, baby. Okay. Did you ever go over this? You see this in mom babies, you see it in some cancer patients, anybody know what might cause it? Not hypocalcemia, you're close. Hypomagnesemia. Right, hypomagnesemia. It can also be because of an MI and some drugs and things like that, but when we tend to see that VTAC looks like this, we tend to think that this is probably a magnesium problem. Okay? That does not mean we're going to run and go give them a whole bunch of mag, because we don't know for sure, because it's the common reason, it's just not the only reason. So, of course, you guys send blood work, but while we do that, we're going to be treating them for that. They can be awake and they can be dead, either way, on that spectrum of like VTAC, because that's what it is. Idioventricular rhythm. So, if your SA And it doesn't have the strength for this muscle to squish it and make it narrow. This does and this does, but this does not. That's why PVCs usually happen now. It does not have the strength to squish this and make it narrow QRS. Does that make sense? At the bottom is weak, at the top is strong. Okay. Looked like I was doing around. Anyway. Oh my God, that's embarrassing. All right. So, that's what this is right here. This is the ventricular. Sometimes you'll see this rounded and it looks more like a baby carriage type thing. That's what I call it. It looks very, very different. But it's driven by the ventricle. What kind of things do you think we might need to do? We could probably put them on some medications to see if we can get a atrial response. Put them on beta blockers or something. What else could happen? We can give them a pacemaker. We can give them a pacemaker. Let's give the atrium some electricity so we can get a P wave going and stuff like that. So they may end up with a pacemaker. What kind of pacemaker you think we might have? So probably have both, right? Because you already have a problem in the ventricle. Okay. MI, digital toxicity, blah, 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 blah. Decreased cardiac output, severe hypotension, weakness, blistering. All the same things because the concept is perfusion, right? Treat the cause. Why are they like that? We're going to treat that cause. You could case them if they have a pulse. Otherwise, we're going to be doing CPR. Most of the time, we don't have to really kind of go down this way. Most of the time, we can catch it and we can transcutaneous pace them until we get a pacemaker. It's kind of cool. All right. You might know what asystole is? Is there anybody who doesn't know what asystole is? Asystole. No heartbeat. Dead. Nada. Nothing. Do we shock that? Nope. Oh, I don't like the word shock and I just used it. Do we defibrillate that? Do we cardiovert it? Why not? Why are we not giving any electricity? Because there's no electricity in the heart. It's not going to capture anything. What are we going to do for this patient? What's the first thing we're going to do for this patient? Check to make sure they're not sleeping and the lead fell off. I've been there, people. All right. He's dead though. So what are we going to do? We're doing CPR. And in CP and ACLS, they teach you that one of the things that happens, and if you can kind of see on here, the causes, they kind of lump them into the H's and T's. And I don't know if I have a slide in there for H's and T's, but it's like hypokalemia, hyperkalemia, hypothermia, toxins, which will cover like drug overdose, tension pneumothorax. There's a whole bunch of them. You can look that up. I feel like I put that in there somewhere, but maybe not. And it can happen because we shock somebody and they didn't come out of it. Shock somebody, defibrillated somebody. Or maybe we cardioverted somebody. I mean, we're messing with the rhythm of the heart. So anytime we do that, we do have the potential for putting them into a system. When we give a adenosine and we change the rate, that might not come back. That's why you have that whole team there, because they will be asystole for a very short time, and then they have a better chance of being resuscitated if we catch that. All right, so we're doing CPR. If we do get a pulse back, we can case them. We're going to be intubated, but we got to figure out why they are the way they are and go through all the measures. If it's a tension pneumothorax, we're going to decompress them by putting that needle in that space, right? You take that 14 gauge needle, and all this air comes out. Anyway, you don't have to do that. All right. Same thing. Ventricular standstill. You can even have P waves. Doesn't matter if your ventricular's not working, right? You're not going to have a pulse. What is your pulse? Your ventricle, right? So it doesn't even matter. Okay, what time is it? Pulseless electrical activity. I did have a patient who wasn't really nice like this, but did have a rhythm. And I think at the beginning I said, somebody came out and said, your patient's dead, and went to there because they have a rhythm on the monitor. Look, they have a rhythm on the monitor. What am I treating? I'm treating the monitor, right? I'm not treating my patient. Patients can show a rhythm and they really don't have a pulse. Okay? And if they don't have a pulse, we're just going to be doing CPR for this. You can't shock it because they don't have a pulse. Make sense? All right. Search for the cause. That means, oh, here's some of your H's and T's: hypovolemia, tension pneumo, cardiac tamponade, hypoxia, your phylemias, your PEs, or your thrombus for your T. And then your drugs and things like that would be your toxins. No P, no pulse, no BP. They're not perfusing at all. All right. This is a really, really nice algorithm. Why do I keep doing that? Okay, this is a really, really nice algorithm. And I want you to use this when you look at that pack. But I want you to understand something, because everybody missed this last semester. And I'm like, oh, I never even thought about it. As you're going through the algorithm, when you get down to like through here, don't forget, a lot of people just want to go down. You just want to go down the algorithm. This one goes across, right? And that's how nursing is. Nursing is very much like this algorithm. You have all these things going on. And you start here, and you're going here, and now you can end up over here, and then that's over here, and that's what you're getting into. That's why it's important to know the concept and then CSI the rest. Knowing what interventions to use, right? Like your 12 week. Okay, but use that when you do your strips, because it does help. Make sense? Pacemaker overview, and this is only because we have a good 5 minutes, and pacemakers do not take a very long time to go over, and then we'll just do blocks when we go to the next model. That is before your test. We'll go over all strips, but especially blocks, so you won't be missing anything, okay? Pacemakers, internal pacemakers, are very easy to pick up on when you're looking at your monitors, okay? If you have your monitors at the nurse's station, you'll see a white straight line, either right before your P wave, or right before your QRS, or maybe right before both. Those are your 3 types of pacemakers, right? If you have it before your P wave, it is a atrial pacemaker. If it's right before your QRS, it's a ventricular pacemaker. And don't be afraid that when you have a ventricular pacemaker, you have this big, wide QRS because it's a reaction to that stimulus, okay? All right. So, what kind of pacemaker is that? It's atrial, right? It is right before the P wave. So there's your spike. That means the pacemaker went off. There's your P wave, and there's your QRS, there's your T, there's your spike. So when they put pacemakers in, they'll set it to a certain rate. So let's say they set it to 70. I always use 70, they always use 70. Okay, so if I have a pacemaker in and it's set at 70, and I get up and I'm walking really fast and my heart rate goes up to 60, or it goes up to 80, is my pacemaker gonna go off? No, because the pacemaker does not go up and down, it only goes 70. So if I have a normal heart rate over 70, the pacemaker knows it doesn't have to fire because I'm doing what I'm supposed to do. But if I go to sleep, my heart rate would go down to 60, my pacemaker will kick in and I'll be at 70 while I'm sleeping. Does that make sense? Okay. So, this one, you have an atrial pacemaker going off 100% of the time. If I walk across the room and stop, maybe it might only have to go off 50% of the time or 25% of the time. You don't have to know all that, I'm just saying. All I want you to know is that you can recognize what kind of pacemaker it is when you look at the monitor, that's it. Okay. What kind of pacemaker is that? Ventricular, right? That's what it's going to look like. Your QRS is going to look very abnormal because it is a big response to that pacemaker. It's going to be exaggerated. So that is a ventricular pacemaker because you have your line right there and your response. You have your line right there and you have your response. Okay? What kind of pacemaker is that? I can tell you that's kind of cheating. This is your AC pacemaker or your dual chamber pacemaker. Either way. Usually you'll have this exaggerated response. You don't really have it on here. This is kind of like a textbook kind of thing. All right, what's this one? Atrial, right? Here's the spike. What's that one? Who wants to go home? Who wants? No, I did not say you could. I just said who wanted to.
Go.
All right. Remember, you can always contact me in the next couple of weeks if you have a question. You will be getting a packet that will help you. I promise it will help you. So not 105 people are calling me and stuff like that. Wait till you get to